Okay, so welcome everyone to today's ARPS webinar. My name is Nicole Willits, and on behalf of the webinar subcommittee, I'd like to say thank you for joining us today, and I'll be moderating the session. I would just like to start with an acknowledgement of country. I acknowledge the traditional custodians of the various lands on which we meet today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present, and emerging, and recognise and celebrate the diversity of the Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Today's webinar, Dose Estimation for Medical Incidents and Accidents, will be presented by Dr. Zoe Brady, Chief Physicist, Diagnostic Imaging and Radiation Safety Officer at the Alfred Hospital in Melbourne. So thank you, Zoe, for agreeing when I tapped you on the shoulder to present this. It's quite an interesting topic for me. Zoe has worked as a clinical physicist for 15 years and has research interests in risks from low-dose ionising radiation exposure and the implications for current medical policy and practice. Zoe is an associate editor for the British Journal of Radiology and sits on a number of state and national advisory committees. And before working as a medical physicist, Zoe worked in health physics on mine sites and oil rigs, and that's where she has a great ARPS connection and has stayed with us to this day. So this webinar will conclude with a question and answer session. So if anyone has any questions throughout the presentation or at the end, please pop them in the chat function and I'll be moderating the questions from there. I will hand over to Zoe now to start the presentation. So thank you, Zoe.
Thank you very much for that introduction, Nicole, and thank you to ARPS for inviting me to give this presentation. And of course, when you asked me, Nicole, I agreed, and then I sat down to write the talk and thought, gee, this is a very big topic. So we'll see if I can give people some of the information and answers that they've dialed in to hear today. So my first thought when I was putting this together was to decide, well, what constitutes an incident or an accident? And this is our decontamination bay in our emergency area at the Alfred. And you can see I'm monitoring one of the other physicists here with our area monitors. And I was thinking, well, all the incidents and accidents that we've had occur here in the past, are we talking about when we had a telecommunications technician present with radiation sickness? What about the sewage leak onto the tram line in front of the hospital, which happened to come from nuclear medicine, and we had to do some dosimetry around that? Or was it the occasion where we had a discharged iodine therapy patient who ended up being admitted to a regional ICU on the way home, unfortunately and very sadly then passed away and required embalming, and so we had a lot of dosimetry associated with that case as well? Or is it the situation where a member of the public presented to our emergency department he'd been sleeping with a rock in his bedroom for more than a year, which he'd ordered online, and he then suspected it might be radioactive, and so he presented with radiation sickness symptoms. So these are some of the strange yet diverse incidents or accidents that we need to deal with within a very large trauma hospital. But really what I think you're here for today is the run-of-the-mill incidents, the dosimetry that we do on a more routine basis for the incidents that are occurring. So these are the exposures that might lead to a millisievert of exposure unnecessarily. Paediatrics, any type of dose is relevant for incident reporting. And then also the category of incidents for high skin doses. So I'll touch on those as well. So sorry to disappoint you if you are looking for the more interesting and unique situations that arise, but I really have, we'll be covering today the more routine and I guess the incidents that we see repetitively occurring. So I'm not alone here at the Alfred. I do have a diagnostic imaging medical physics team, and we certainly all have different expertise. So I've got Nervadesh in nuclear medicine. I'm the chief physicist and cover predominantly radiology. And then James Crocker, who comes from New South Wales, Nicole was mentioning at the start before we started the presentation, he's our deputy radiation safety officer and our senior nuclear medicine physicist, and Kyle, who's in radiology and covers radiology incidents with me. So I think the breadth of what I'm presenting here today is certainly not covered by myself. We all have our area of expertise, and we also have each other to bounce ideas off when we've got a really complex case. What I'll talk about today is several modalities. I'm going to cover general X-ray, CT, nuclear medicine and PET, and fluoroscopy. So already you should be thinking, wow, how are we going to fit this in? And I'm going to try to and give you some basics across all of those modalities. When I think about the dosimetry methods and what to share with you today, there's a few that I decided upon or thought about when I think about dosimetry. One is direct measurement. So I'm not going to cover this today, as this is not the sort of thing that we can do retrospectively for incidents. When I talk about direct measurement, I'm looking at TLDs, OSLs. This is an angio case that I've shown in the photo here. The other type of common dosimetry is with phantoms. This is a phantom with MOSFETs inserted, and I'm not talking about that type of dosimetry today as well. So that was one way that I managed to cut the talk down a bit. What I will be talking in detail for each of these modalities is looking at some Monte Carlo methods. Now, the non-physicists in the audience might not be familiar with those. So I'm going to give a very introductory level slides on Monte Carlo, but also to point you to some of the tools that can be used, which I have seen. I have a number of senior radiographers who contact me regularly about these tools and using them. So everyone has an opportunity to have a look at them after this talk, download them possibly. Most of them you do have to purchase, but with some guidance and with the user manual, they can be quite useful. I'm then going to also, for each of the modalities, touch on conversion coefficients. And I think we also can't underestimate published values. With this type of dosimetry, you really need to see if you're in the ballpark. And I certainly will look to peer-reviewed literature for most dosimetry that I perform. A very quick revisor of some of the dose quantities and units. We start with absorbed dose, which is the amount of energy deposited per unit material. And so this is measured in the unit of Gray. We use this specifically for skin dose estimates when we're looking at reportable incidents. So I will come back to this quantity later on when I talk about skin doses. When we take into account the type of radiation via the radiation weighting factor, then we end up with an equivalent dose in sieverts. To be honest, we don't use this quantity a lot in our these types of dose estimates because we're dealing usually with a radiation weighting factor of 1. So if I'm looking at an organ dose or a skin dose, I tend to use the absorbed dose quantity of Gray. Then when we take into account the tissue radiosensitivity via the tissue weighting factor, we have our quantity effective dose. This is primarily what we're using for incident reporting. It's measured in millisieverts, or if you're doing X-ray dosimetry, then you might even be doing that calculation in microsieverts. Just a little bit of a word of caution. Effective dose is a measure of the risk of late effects, so hereditary and cancer effects caused by ionizing radiation. It allows us to account for that partial body irradiation. So we can compare something like this CT scan that you can see here with a coronary angiography or a nuclear medicine scan. It allows us to make that comparison. But it's not specific to an individual. A stochastic risk is dependent on age and sex. And so those tissue weighting factors are derived based on the underlying age and sex distributions of workers in the general population, which was used to calculate those. So we shouldn't be using effective dose for individual dose estimates. However, it is commonly used for incident reporting, although this type of individual use is typically not encouraged, particularly by ICRP. So in terms of Monte Carlo modelling, and the reason that I wanted to introduce it a bit today was for the non-physicist people who are tuning in. This isn't something that is abstract and something that you can't touch. I think that it is possible with the calculators that are available today. Most modern dosimetry is based on Monte Carlo calculations. It's stochastic in nature if you think of gambling. So what we do with a Monte Carlo simulation on a computer is we model the CT scanner or the X-ray unit and the tube and filtration, for example, and then we follow 1 million X-ray photons or more, and we look at where that energy has been deposited within the phantom that we're using to simulate the human being. It's still a lot less X-ray photons than in a real X-ray beam, but statistically it provides us with a really good dose estimate. It's very robust, but the limitation is the phantoms, and most of these are what we call mathematical phantoms, and you'll see them on my future slides. They don't look very lifelike. The ones that I've shown you here on the right are from one of my research colleagues, Chun-Sik Lee, in the US. So he's developed these through the University of Florida and the National Cancer Institute. These are much more lifelike. So they're voxel phantoms and are becoming, you know, each time I see an iteration of these, they're now accounting for different habitus, different obesity levels on individuals. And the paediatric phantoms that they've developed have now been adopted as the standard for the ICRP. But what you need to take away from any of this Monte Carlo modelling is that it's not patient specific, because you're modelling the dose to the patient based on the phantom that you are using. In diagnostic imaging, we then use a number of different calculators, and they have underlying Monte Carlo data sets that have already been generated for you. So you won't be writing computer code, you won't be doing the programming or the modelling of the CT scanner. You'll be using what's like an interface, and I'd call it a calculator, that then draws on these Monte Carlo data sets that have already been generated. The other topic I wanted to touch on, and I saw Peter Thomas was on the call, although I can't see most names on the call at the moment while I'm presenting. So Peter's at APANSA, and I wanted to touch on diagnostic reference levels. DRLs, I think, can be used to give an indication of a dose for an exam type. So if you've got an incident occurring at your site, or you're a consultant and you've been asked to do a dose estimate and you have no idea where to start, then I think that you can have a look at the Australian DRLs as an indication of what might be a dose range for this type of exam. A DRL is an optimization tool. It's a form of investigation level, and it's used to indicate whether in routine conditions the amount of radiation is unusually high or low for that procedure. So if someone maybe a little bit bigger than me goes in, so of a standard size, which is considered to be about 70 kilos, goes in, has a typical CT chest scan, what type of dose would they get at an Australian practice? These diagnostic reference level values are set at a national level by APANSA. So a lot of sites voluntarily submit their data to APANSA. The median value is calculated for each hospital. So our CT chest scans at the Alfred, we calculate a median dose value for a standard size patient for our typical CT chest protocol. So we actually do it by collecting data for 20 patients. We get the median value, and then APANSA sets a national DRL at the 75th percentile of all the median values that they've collected across Australia. So it gives you a really decent indication of what Australian typical practice might lead to in terms of dose for an exam type. All right, let's move straight into the modalities. So I'm first covering general X-ray. You may not need to do a lot of dosimetry in this area because most doses won't exceed a millisievert, unless you're working in paediatrics where everything is reportable if it fits the definition of an incident. One of the quantities that you might find useful is the DAP, the dose area product. It is more correctly called the Kerma area product, but since I've been working for some time, I haven't been able to change to the new terminology, and I do refer to this as the DAP meter. It's a useful quantity that is displayed on most X-ray units. So if you haven't had an X-ray unit replaced and it's 15 years old, you might not have it, but anything new these days will have it displayed, or you should ensure that it is in your tender requirements. So the DAP is useful because it doesn't change through, based on the distance from the X-ray tube. So it takes the dose at that point, multiplies it by the area of the beam, and what you can see is that we've got this quantity that is constant no matter where in the beam we're measuring it. Some units, X-ray units, will have a DAP meter, or a physical DAP meter, like this picture that I've shown looking back into the tube of one of our X-ray units. Some will use a lookup table based on the parameters that have been used for that X-ray exposure. So this is one of the dose quantities that, if you have it available, you might use, or you might even submit this value to your regulator if they accept the quantity as an indicator of the dose. One of the really tricky things is that every single X-ray unit will spit it out in terms of a different unit. So gray centimetres squared is the one that we would use for any peer-reviewed publications or any conversion coefficients. So I would suggest that you convert to gray centimetres squared. A lot of X-ray units will give it to you in decigray centimetres squared, or you'll have others that'll be microgray meters squared. So I've just given you this table as a bit of a reference. I always have to double check it. I always think, wait a minute, I don't think that is quite right, but I've had several people check this one, so hopefully I've got it right this time. But that is one of the hardest parts of dosimetry when you're using DAP, is to get it into the correct unit of measurement. So this is the Monte Carlo tool that I use most regularly for general X-ray. It's called PCXMC, and I've given a link to it at the bottom of the slide. It's actually produced by, I think it's the Finland radiation regulator. So you do need to purchase this, but if you work at a hospital, then certainly getting a single license might be quite a viable option for you. One of the nicest, so first of all, you should notice that this is a mathematical phantom, and you can see that that certainly is not going to match all the variety of patient sizes that you will get. So that's one of the limitations of using this type of dose estimation tool. One of the nice things is that you've got different age groups here that you can select. So if you're doing paediatric dosimetry, then this tool is useful for that. You put a number of parameters into the program. The first page that I'm showing you here defines the field of view, defines which projection angle that you've got. And also this is where, if you know your source to image distance or your air gap, you can work out what your field of view at the skin entrance of the patient is. So you do need some parameter information. From here, you go on to do a calculation using the beam quality for the actual X-ray that was taken on the patient. So there you'd need to know the KV, and you'd need to know the filtration for that X-ray unit. In terms of a dose metric that you input to get the final dose estimate, it can be an MAS value, an air Kerma, or that on what I mentioned on the previous slide, it can be a dose area product values. That's useful where you've collected that. With this program PCXMC, you then will get an output of the organ doses in milligray. So that might be really useful if you're wanting to look at a specific organ, like the uterus, for example. From here, effective dose is then calculated in millisieverts and displayed. I don't use it very often, but PCXMC also has a module where it does a risk estimation for you, so you might find that useful. This is the same tool that I would use for a fluoroscopy dose estimate, and in fact they have a rotational module available as well, where you might start to have those 3D spins occurring in fluoroscopy. You probably need a little bit more understanding of how the program is working to do those sorts of estimates. I think at this general X-ray level, it is quite useful tool. So some of the handy tips from what we do here, we have a template for data collection, and that's because when I first started out, I'd ask the radiographers questions, and then I'd be back 5 minutes later, and then I'd be back again 2 hours later, and then I'd be back again the next day, because I would never collect all the information that I needed if I was trying to do this sort of dose estimate. So we now have a template that actually my registrars have made up, and is very, very useful, that just documents all the relevant information and make sure that you collect it when you're speaking with the radiographer, or when you're looking at the image and maybe you're managing to get this information from the DICOM header, for example. We compliance test all of our X-ray units, and that's a benefit of being here on site. So we have a lot of the technical information already available, like the filtration in terms of the aluminium or copper that is used on that X-ray unit. So if you're not familiar to the site, that's certainly something that you would need to ask about. If you're speaking with a radiographer, or maybe you're the radiographer who is doing this dose estimate, then it's also useful to ask how the X-ray was performed. One thing which doesn't appear on packs are the images that weren't accepted or repeated. So sometimes for incidents, I've found that it might be a chest X-ray, but because of mispositioning of the patient, they'd taken one, rejected it, and then only one image got sent through, but in fact 2 images were taken. So I think that that's an important question that can really change your dose estimate by a factor of 2 or 3 very quickly if there were multiple images performed, but then rejected. It's also useful to ask about the source to image distance. I find radiographers are so good at just looking at a distance and going, yep, that's 1.1 or that's 1.8 meters. There's a lot of standard distances that they use as well. If you're not used to the terminology and the acronyms, it can really throw you. It did when I first started out. So this can all be referred to as the SID, the source to image distance, or the FID, the focus to image distance, or even the FFD, the focus to film distance. So don't feel like you're out of your depth with all the acronyms. This is where a template really helps to go, okay, what was the SID? And then the radiographer might say, oh, well, the FFD was this. And you can then know that that's what they're talking about. The other important question is to see if they have a standard protocol and what views are included in that protocol. So here at the Alfred, we have a work instruction for each type of X-ray. And so what I mean by this is, when they tell you, or there's a risk man that says that there's been a chest X-ray incident, well, is a chest X-ray just a chest X-ray? So for example, at the Alfred, we would do a posterior anterior chest X-rays as our standard view. But on first presentation at the hospital, we also do a lateral chest X-ray. And there's another of other indications where a lateral is performed as well. Why is this important? Well, for my dosimetry, for a PA chest X-ray here, it's about 0.02 millisieverts. But if I have to include a lateral view as well, then immediately I'm up to about 0.1 millisieverts. And you might think, oh, okay, well, that's the main chest X-ray views. Well, here's our work instruction. There's a whole lot of other views that can be taken as well, which you may not have thought of it as part of a chest X-ray, but can be, depending on what the clinical request has been for. The other trick, particularly in a hospital, is to find out if this was done on the ward, and then it will usually be an AP because the patient is lying in bed, and that will change your breast dose quite significantly because the X-ray beam is incident on the front of the patient rather than the back of the patient, which is what we usually do for a standard PA view. So these are some of the discussion points that you would have with whoever's providing you with the information for the dose estimate for the incident. I've provided here some of our typical patient doses and also given a column for the background equivalent radiation time. Look, these really vary depending on patient habitus and size, and also the radiographer technique and protocol that they've used. But this is just to give a little bit of an indication. And I think that if you are doing this type of dosimetry, then you sort of want a bit of a lookup table of, okay, well, what's a typical dose? Certainly, as I've got new people starting and registrars training, then I try to give them a feel for what the doses are. As you get into the thicker parts of the body where you've got more X-ray attenuation, like the pelvis or the lumbar spine, then you'd really expect those doses to be a bit higher. So I'm always asking when we do dosimetry here, well, does that dose make sense? So if we calculate 2 millisieverts on an abdomen, I would be hoping that that's quite a large patient, because that would be an unusual dose for us to see for a patient for a typical abdomen X-ray. There's also useful guidance in the APANSA safety guides, and I look at this quite regularly. I think if you don't know that it's a resource there, then you should certainly have a look at this. It gives you some dose ranges for typical X-ray views. All right, so moving on to CT, as this is where we have more reportable incidents. The type of dose metric that's important here is the volumetric computed tomography dose index, or CTDI-vol. Now, this is what I equate to the output of the X-ray beam, but at a single point in that beam or a single rotation, it combines all the parameters that have been used, so the KV, the MA, the rotation time, your beam collimation, and your pitch. It tells you how much is being put out by that X-ray tube. Because it's at a point within the scan, and because in most cases this quantity MA will be changing throughout the scan, so as it goes through these sort of air cavities of the lung, it might be a lot less, but as it goes through the shoulders, which are very attenuating, that tube current will increase so that you get the image quality required. So what you get output on the scanner at the end is actually an average across the whole scan volume. So it's an average CTDI-vol. Now, the other thing to know about this dose quantity is it's not a measurement in that patient that you see there. This is a measurement where if we'd used those parameters and we measured it in these Perspex blocks, this is the value that we would get. So it's really important to understand that that is a measurement made in Perspex and not in the specific patient that you have on the table. And there's certainly a lot of publications, which I'm not going to go into today, about then making a size-specific dose estimate for a patient. So this is the 16 centimetre diameter phantom, which we use for heads, and this is the 32 centimetre diameter phantom, which we use for bodies. For a child's body, depending on the age, we might revert to this 16 centimetre phantom size. From this CTDI-vol quantity, we then move to DLP, or dose length product, which is very useful for these types of dose estimates. This now takes into account one additional parameter, which is our scan length. So you can see here we're now multiplying that CTDI-vol by the entire scan length, and we get this odd unit of milligray times centimetres. So with these quantities available to us and the parameters for them from the exam, the different Monte Carlo options are Impact, which was developed in the UK. It's no longer funded, so it's not updated for new CT scanners, and you do need to purchase the underlying Monte Carlo data set. It uses the MERD anthropomorphic phantom, which has a weight of about 73 kilos. CT Expo is another good option, and the one that I use currently. It's developed in Germany. You do need to purchase it. It includes a lighter female specific phantom as well as a male, so it's got a 60 kilo phantom in there, and also a 7-year-old and baby. There's another option that I use called NCICT, which comes out of the US National Cancer Institute, but you do need a user agreement that you might even have to go through your legal team for. It has that improved range of phantoms. So particularly if you're working in research, then this is probably an option that you'd look at. I do think that these need a more experienced user for some aspects of them, but of course it's something that can be learned. Most of them do not take into account dose modulation of the scanner, so where that tube current changes throughout the scan. And if it does take into account the modulation, then it might not take into account the specific modulation that's been applied on your scanner. So for example, CT Expo will allow you to include that the scan has been dose modulated, but it then uses its own curve, which is based on a Siemens scanner. So that's all happening in the background. So you do need to make some judgment calls around that. These tools also don't include overranging in helical CT, where you've got an additional half to full rotation that's acquired so that the data interpolation can be performed for a helical scan. So these are some of the, I guess, professional decisions that a physicist would make when using these types of tools. This is what impact looks like. I've got the website here. You can see, again, the mathematical type of phantom, and we've only got one phantom available in this tool, so we don't have paediatrics, although there are some paediatric modifying factors that are provided. Here you select the type of scanner. The underlying Monte Carlo data set is what you've purchased. And then you've got some parameters that you put in, and you can see you get this CT-DI vol and DLP, which is useful to compare to what's being displayed on the scanner. And in fact, you might adjust your parameters to make it match these values. Here you get the equivalent doses, so for each of the organs, and then it does that effective dose calculation. This is CT Expo, so you can see you've got a male and a female version of the phantom, but otherwise it's similar in the sense that you pick your scanner type, you have a range of input factors, and then you get those organ doses and an effective dose as part of the calculation. So handy tips for CT, well, there are many more parameters to collect, and these actually are vendor dependent in some cases. A word of caution is to always find out if it's MAS or effective MAS that's being provided to you, as effective MAS includes the pitch factor in that quantity. Usually I don't estimate the dose for the initial scalp view, as it's a very small percentage of the total scan dose, unless the incident is about the scalp view in particular, and then that's where I will calculate it. And you can do that through CT Expo if you need to. And talking about vendors and how everything is specific to the vendor, I've just given an example here. Each of them called the scalp view. I call it the scalp because I've mostly used GE scanners, but each of them call it something different. So Siemens call it a topogram, Canon a scanogram, and Philips a SurView. So when you're having a discussion with the person who's providing the information, it's useful to speak the same language as they're seeing it displayed in, and that just comes with practice, particularly if you're at a site where you're dealing with one type of scanner. Then you can ensure that you're understanding that vendor specific terminology. Again, it's very useful to talk to the radiographer about the parameters and the protocol. I've just given an example here. I've shown you a scalp view of a patient's torso, and for a chest, abdomen, pelvis scan, when I first started, I would have thought that that just means you go from somewhere around the shoulders down to the bottom of the abdomen pelvis region. But in fact, a lot of our chest abdo-pelvis scans are performed as a chest scan first, and then we do a second scan, which is an abdomen pelvis, and I've shown you the range here. So in fact, you get this region where you've got a duplication of the dose. So if you're not understanding how the protocol is performed at that site, then it can really affect your dosimetry. You'll find that none of your parameters or your output DLP is matching up, and it might be for reasons such as these. The easiest mistake to make is to not ask about the number of phases for a CT scan. So for example, a CT brain without contrast and then with contrast enhancement will be double the dose. So again, it's having a template, making sure you're clearly asking these questions so that you know what has been involved in the scan. Also, as I mentioned, that CT-DI vol quantity is actually measured in one of those two-sized phantoms, and this can also lead to incorrect dosimetry if you don't know which phantom size your CT-DI vol has been displayed in terms of. The area that's most problematic for this is the neck. So, for example, at the Alfred, we'll actually do these on a body filter, which means that it's the 32 centimetre phantom. But when you first start, you sort of think, oh, well, the neck's small, they'll be doing that with the smaller 16 centimetre phantom, just like you would for a brain scan. The other area where I've been caught out with this is on radiotherapy CT scanners, because they will often scan everything on a body filter, which means all dosimetry is in terms of the 32 centimetre phantom. So it's important to just clarify that when you're collecting all of your parameters for the dosimetry. It will result in a difference of a factor of approximately 2 on your dose estimate if you're using that value directly in your calculation. So the easiest way to perform a dose estimate if you're needing to do these is to use the DLP value and to use a dose conversion coefficient to then convert this to an effective dose. I've provided here the set that I regularly use. It's a paper by Huda, and it's got effective dose in terms of the ICRP 103 definition, so the more current definition. With these conversion coefficients, I've given you just the head in terms of a 16 centimetre phantom, and these other values are all within, in terms of the 32 centimetre phantom. So, for example, if you had a CT brain scan and it said the DLP was 800 milligray centimetres, to calculate the effective dose, you'd take that 800 and you'd multiply it by 0.0024, which gives you an effective dose of 1.9 millisieverts, or 2 millisieverts in this case. So this is where the DRLs come into play. And if you really have no idea where to start, or maybe you don't have all the parameters available to you, sometimes you really have to do dose estimates for incidents with very limited information. And this is where I'd have a look at the DRLs. So these are the current national CT values. You've got a value for the CT-DI vol and a value for the DLP for some typical scan types, including the indication for these. So it's just another reference that you could use to look at, am I in the right ballpark with my dosimetry? And I've provided here some typical CT doses at the Alfred. I've got 17 millisieverts for a chest, abdomen, pelvis scan. We're probably doing more these days at around 10 millisieverts. But what's really interesting is that when I do incident reporting, usually it's larger patients, and recent dose estimates for a chest, abdomen, pelvis have been 25 millisieverts, 30 millisieverts. So it really can get up there. Again, the APANSA safety guides also have some typical dose ranges for CT, which you might find useful. So I also wanted to demonstrate that even if you put a question to a group of diagnostic imaging physicists, you will come out with a range of answers for this type of dosimetry. This is an exercise I did a few years ago. I've anonymised everyone, as you can see here. And it's a range of DIMP physicists in Victoria from a couple of years' experience to decades of experience. And sure, there's some of these dose estimates, particularly the brain scans, even on a paediatric, where we're all within the same sort of range of each other. But this one, a brain and a cow, which is a circle of Willis, so includes the neck region, you can see it's immediately throwing people, and we've got a real range in the dosimetry there. Even when you get to the paediatrics, we've got one real outlier in that dose estimate. So it's not an exact science. It really is a lot of interpretation of those parameters and then how you use them to calculate the dose required to be reported to your regulator. Nuclear medicine and PET. So I actually find this a lot easier. You need to know the radioisotope, what pharmaceutical it has been labelled to, the patient's age if you're doing paediatrics as well, and the administered activity. With these, don't forget that you often have to do a CT dose estimate as well. So if you've got a PET CT scan or a SPECT CT scan, so make sure that that's not forgotten. With these, I find them a bit easier because I often use the conversion coefficients that are published by the ICRP. So for example, here we've got a techie bone scan. So we can go to the table in ICRP. You need to know what MDP is. So it's a diphosphonate. So here I've gone to the table for the phosphonates. For an adult patient, I'm using a typical administered activity of 800 megabecquerel, and then just using this conversion coefficient to calculate effective dose, which I've demonstrated here. If you wanted to calculate an organ absorbed dose, then you have that option here as well. For nuclear medicine, our doses are sort of below 10 millisieverts per scan. Here, PET-CT, we're probably at around 10 millisieverts these days, as we have done some optimization on our CT protocol as a result of optimizing for DRLs. For nuclear medicine, Abhansa do provide a lot of DRL, so I've given you only a really small excerpt here, and I've included the bone scan, which is what I've done the dose estimate on the previous slide. So again, it's giving you some good values here on the administered activity, so as the median as well as the DRL, so you might find that useful. Although, of course, your incident might be the result of administering completely the wrong activity, and so that's where these would then not be useful, and you really need to look at the specifics of the incident you're reporting on. There's also DRLs for PET, both with a fixed activity but the body or weight corrected values, and also for the CT scans. So you can see here from the units of measurement, milligrays, centimeters, that these are dose length products, and so they might be useful to you as well. I just wanted to touch on briefly extravasations. Not everyone reports these. In nuclear medicine, we do report them. This occurs when the injected radiopharmaceutical leaks into the surrounding tissue. So it can result in a localized tissue retention and then subsequently an unintended extended local radiation exposure to that part of the skin. This paper is really useful. So if you need to do any dosimetry in this area, then I would definitely recommend looking at this paper from 2017. They did a really extensive literature review, which came up with 3,000 total reported extravasation cases. Interestingly, only 3 have reported radiation injuries, erythema and ulceration in one case. But it's interesting to look at which radioisotopes those are attributed to. But this is certainly a really good reference if you're suddenly having to deal with this type of clinical situation and being asked for advice or to do the dosimetry. The dosimetry is not straightforward. At the Alfred, we make a few assumptions. So we assume that the extravasated activity accumulates under the skin as a spherical volume. This really recent paper, which is a therapy dose, so it's lutetium, you can see here the extravasation on the patient, and what you can see is it certainly doesn't look very spherical, but this is one of the assumptions that we're making, and they actually go through this paper and do the same. We also assume that the activity within that extravasated volume is uniformly distributed, and for, I guess, a worst case estimate, we assume there's no biological clearance from that volume at all. It's only the physical decay that we're considering. The skin dose within the spherical volume we also consider is much higher than any of the other dose or contributions from regions outside of that volume. And I certainly, and I should have said this disclaimer up front, I'm showing you our way. It's certainly not necessarily the right way. It's just, this is the way that we are doing our dosimetry currently, but it's continually informed by our peers and also by the literature. So for the skin dose estimation, we then use published dose kernels, which is just the absorbed energy per decay radius from the source. All our estimates so far for diagnostic nuclear medicine extravasations, luckily we've had no therapeutic ones, have been less than 2 gray, which is the threshold for erythema. So what we're doing in our estimations is providing an upper bound of the dose estimate rather than a specific estimate for that patient. There's not a lot of literature in this area. We don't tend to image as the patient has already usually been given another diagnostic dose so that their actual scan can be performed. And they've either already left the hospital at the time we're notified, or it's only been a partial extravasation. Or if, for example, it was a renal scan, then we won't necessarily see images of the arm and the extravasation in the scan volume. So we have been discussing this recently, that it would be helpful to get a time series, as you can see here for this patient. This is the lutetium extravasation, and these SPECT images are at 5 hours post, which is really giving you some interesting information in those images. We did benchmark, and this is one of the Australian Radiation Incident Register reports from a couple of years ago. And so nationally, there was 13 extravasations reported. And when we looked back at 3 years for us, we had a couple of years of none or no reporting, I should more precisely say. And then we did have a year where we had 6. So it is, it may not be common practice to report. We certainly are, but we certainly are performing the dosimetry for these so that we're informing both our clinical staff and our patients where necessary about the potential skin dose. All right, so talking about skin doses, then we obviously want to talk about fluoroscopy, and this is where the entrance skin dose is important, particularly the peak skin dose, which is receiving the highest area of radiation. Air Kerma is defined at a reference point and can be used to estimate this peak skin dose so that we can then assess the potential for tissue effects. Fluoroscopy time is not a good dose surrogate for these cases. It doesn't tell you any information about the dose rate at the patient's skin, the field size or location, or whether it was fluoro or acquisitions or DSA that was being used. For the effective dose, the dose area product, as I introduced earlier, is useful for determining effective dose. With the Air Kerma, it's measured in milligray or gray if you're getting up to these higher dose levels. The cumulative Air Kerma is at a point in space, which is located a fixed distance from the focal spot. For isocentric systems, which will be most of them, you have the isocenter, and then this point is defined as 15 centimeters towards the X-ray tube. It's ideally the point that will coincide with the patient's skin entrance, but this will not always be the case. So that's one thing that you need to check when using this quantity. If it's at a different point, then you will need to use an inverse square law correction to correct for that. The other thing to note about this Air Kerma value is that it does not include the backscatter from the patient. This is about an additional 30%, but really does depend on the beam quality, so the KV and the filtration. It also doesn't include the table attenuation, so the tabletop and the mattress will provide a fair bit of attenuation here as well. So these are some of the factors that we take into account when we're looking at that dose, displayed dose, and then determining what the peak skin dose for the patient is. It's displayed during the fluoro procedure and also at the completion, and it assumes that all the radiation has gone in that direction. It's a cumulative measure. So when we're doing a more precise dose estimate, then we'll look at the beam angulation and if some of that dose has actually been spread across the skin rather than all incident on the one location. We produce a report for the higher skin dose patients where we give an indication of where it is on the patient that we expect to see, any sort of tissue reaction, what the dose may be. The reason we do these calculations is because in Victoria, we need to report those that exceed 6 gray. Often, so this one had an entrance Air Kerma of 5.9 gray, but when we took everything into account, the actual skin dose to the patient was probably closer to 4 gray. And we also provide this map of how the dose has been spread if there's been quite a bit of beam angulation or the beam has been moved around a lot during the procedure. So there's quite a lot to take into account for these peak skin dose calculations. We did have a look at previous annual reports from the Victorian regulator. These are all the cases that were reported for high skin doses over a 3-year period or 4-year period. And We then matched them to the ones that actually reported a skin reaction. So what you can see here is that they're not really kicking in till around 8 Gray. Remember that threshold of 2 Gray for transient erythema is the threshold dose where you will see that reaction in 1% of the population. So it was interesting to do this exercise, or my registrar did this exercise, and you can see as we get into the higher doses that it is correlating with some observed tissue reactions. Of course, one of the issues related to this is that we often report quite quickly on these incidents, and certainly the follow-up of the patient may not have occurred in that time frame, or follow-up may not have occurred at all. We lose a lot of these patients, I think, to lack of follow-up. I've put a couple of tables here for those who want to do the type of conversions to effective dose from your dose area product value that's been displayed. So there's, I find the best place to go for these is the IAEA ARPS resources, and they provide quite a lot of these. Some of these I've supplemented some values from the NCRP as well. If you know the type of case, so you know the type of anatomy that's been imaged, then you can use one of these conversion coefficients to directly calculate the effective dose from that DAP value that's been displayed on the scanner. And it depends what you're trying to calculate for these cases, whether it's peak skin dose or effective dose. There's a DRL, but only one in this area for coronary angiograms, so that might be a point of reference for you. And similarly, just alerting you to the fact that the APANSA safety guides have some dose ranges for these types of examinations as well. All right, finally, a very small part on fetal dosimetry. Absorbed radiation doses to the fetus are properly expressed in milligray, but since we're dealing with a radiation weighting factor of 1 for X-rays, and given the homogeneity of most fetal exposures, so usually it's quite early in gestation, so you will usually get the entire fetus exposed, then millisieverts is sometimes interchangeably used for these dose estimates. Usually we use the uterus as a surrogate for the fetal dose. So all of those tools and calculators that I've shown you earlier, we would take the uterus dose as the fetal dose. It's probably only a good approximation in the 1st to 2nd trimesters, and the 3rd trimester, these estimates are certainly not trivial and probably will require a medical physicist. Again, the APANSA safety guides provide you with some good estimates for these. With X-ray, and it's amazing, these images, you can see the spine of the baby here. The fetal dose can be approximated by the entrance skin dose, if that's known, and you can use a percentage depth dose table to calculate this. These tables are based on the beam quality, and the depth of the fetus assumed to be about 8 centimetres below the skin entrance. So a rule of thumb, if you know the entrance skin dose, is that the dose to the fetus will be about 25% of that. And I've just given an example here where an entrance skin dose for an abdomen X-ray was 2.5 milligray, and so we can approximate the fetal dose at 0.6 milligray. CT, you might think, is more complicated, but potentially is a little bit easier, because the uterus dose, if it's directly in the scan volume, is normally around 10 milligray or 10 to 20 milligray. And so in the 1st and 2nd trimester, this is a good approximation of the fetal dose. Of course, you can go through the Monte Carlo calculators and calculate the dose to the uterus. But 10 milligray is a pretty good idea of the dose. You could also look at what that CTDI vol value is, and that will give you a bit of an indication of what the typical organ dose is within that primary X-ray beam or scan volume. Remember here, you definitely need to consider the number of phases. So something called a triphasic liver scan, which sounds like 3, here at the Alfred involves 4 scans, and that's certainly going to increase your dosimetry considerably for a fetal dose estimate. Most other types of CT scans, like a brain scan or a cervical spine CT, will have very low to negligible exposure to the fetus, which will all be due to internal scattered radiation. For nuclear medicine, there's a good paper where you can use a conversion. You can use the ICRP conversion coefficients for the uterus, as you saw earlier. But this paper is probably where I would go by Staben, and you can calculate a dose estimate depending on the stage of pregnancy. So this is quite useful. I always get asked about CTPA scans versus VQ, which might be used on a lot of pregnant women when they present in an ED department. For typical parameters at the Alfred, the fetal dose for a CTPA is less than 0.1 milligray, and a VQ is up to about 0.5 milligray, so well below the threshold for any detrimental effects. What's interesting, or the distinguishing feature between these two scan types, is probably the dose to the breast for the mother, which is much higher on that CTPA scan, and you've got almost a twofold difference in effective dose. So in conclusion, I was asked by Nicole to give you a primer, but because of the number of modalities and methods that I've tried to cover, I think what I've given you is more of a taster of the different dosimetry options available. I've given you a really quite brief introduction to the various dose terms and provided you with some different avenues to pursue for dose estimates. I've given you a lot of conversion coefficients, which you might need to look back if you ever need to do dosimetry in one of these modality areas. And these are useful for calculating effective dose. But I really can't undersell enough that, or really emphasize enough, that published values and checking peer-reviewed literature is also really helpful for these types of dose estimates. And using DRLs to ensure you're in an expected dose range if it is a standard procedure. And particularly if you have no other parameters available, then this is perhaps a really useful indicative dose or starting point for your dose estimate. And with that, I will conclude. I know I've cut it very fine with time. Thank you, Nicole.
No, that was perfect, Zoe. That was a lot of information squished into. You did well. You got under the hour, so thank you very much. I know that was just, yes, it was definitely a taster. And even someone like myself who works in paediatric facility, just the reiteration of how different it can be across the scope of modalities, and for me, the different age brackets. That's been really useful. I'll just wait a little bit while, if anyone wants to pop any questions into the chat box for Zoe, we've probably got another 5 minutes. But I've just got a quick one, because based on all those calculators, which looked fabulous, but there were a lot of decimal points. Where would you draw the line in how many decimal points or scientific numbers you would go to for something like this, when it is really an estimate?
Yeah, well, as I think the thing to remember is that there's a lot of assumptions made in any of these dose estimates, so that certainly precludes you from using a lot of decimal points. So I'd say if you're doing a dose estimate that's over a millisievert, then I would expect to see it possibly rounded to the nearest millisievert. We're really conveying a false sense of accuracy by doing much more than that.
Yes, it gets very interesting at the paediatric level, where it's the doses are quite low.
They're so low.
You're already trying
I like to say less than 0.01 millisieverts a lot. I really get uncomfortable with using microsieverts. Of course, when you do paediatric dosimetry or you're looking at the extremities, that's the dose range that you're quoting in. But where I can these days, I do tend to say less than 0.01 millisieverts.
Yeah, no, that makes perfect sense. So just because obviously different regulators, different states and territories have different requirements. So I'm in New South Wales, you're in Victoria. So in New South Wales, on our incident report form, we could submit in milligray, millisieverts, or DLP. So for those who are non-physicists, you can actually report in New South Wales in DLP if that's easier, if you have that information. So you don't need to go to such a great detail.
And I certainly, if you do that, and it's something like the neck region, or if it's pediatrics, certainly put in brackets, 16 centimetre phantom or 32 centimetre phantom, and your scanner will tell you on that dose protocol page at the end of the scan, because that is needed to fully interpret that number.
Yep. And just haven't seen any questions come through. I think everyone's a bit bamboozled, but just one query. is there any advice, or what advice or preference for someone that doesn't have a physics background trying to grasp which method should they look to first?
Yeah, well, I think that a lot of the reportable incidents that we deal with are in CT, and I think that that's where I would use the dose conversion coefficients, so that you can get an indication of effective dose by just multiplying that DLP value by the appropriate conversion coefficient. I think that's a good starting place to get an effective dose. And I just can't emphasize enough, just double checking what you're doing. Does that seem like a reasonable number? And if you've calculated an effective dose, then you can do that more readily.
Yep, no, that's great. I always double check mine, because sometimes you can put it, just converting some of them from the different units that might be available on older machines as well, as you pointed out. That one always gets me. I don't know how many times I've done it, but I even have a cheat sheet of what I have to do,
and I still don't get it right.
So someone's just popped in the chat if you would be up to sharing your templates for that data collection for the different ones. Obviously not reinventing the wheel. We like
yes. Well, the templates are a little bit more complex than what I showed on the screen. I am happy to provide them, but I don't have instructions that go with them. Maybe if you email me directly, then I'm happy to provide you with a couple of our templates with them, and then you can check back with me if you're using them. But I certainly would say that, you know, your dosimetry is then yours from that point on.
Yep, I'm just quickly looking through the chat, because some are coming through. The extravasation, I always can't say that properly.
Yes.
Incident reports, I know that's very much underreported across the country. And I think it was highlighting how hard it is actually to calculate any skin dose from that, because most of the time we find out after the patient has left, as you have said, and it may not have even been in the image capture as well. So I think that's just something that we all need to be aware of. And if you can, the biggest issue I would reiterate is in therapies for that, where we definitely want to be looking at the skin dose to that patient. Sorry, Riaz, I'm just going to read yours out directly. Skin dose limits for members of the public and professionals are based on the maximum 1 centimetre squared area exposure. In reality, as have shown, the exposure can be non-uniformly distributed over an area. Is the concept of setting a limit on the basis of max exposure realistic?
I think as a member of the public, dose limits so we don't use dose limits when we're talking about medical patient exposures. So I'm not sure of the question, given that dose limits don't apply for medical diagnostic imaging.
Okay, perfect.
So it would be with a worker that you're measuring rather than a patient, though.
Yeah, certainly. So I think that was Daniel. Certainly dose limits apply to occupational exposure, but I think some of those, like that question, Riaz, I might have got your question wrong, but I think you were your question is in relation to that medical clinical scenario that I showed. So that's definitely a patient exposure, not an occupational and not a member of the public exposure.
Yeah, but that actually, mind you, Daniel did point out a thing that we can have incidents where occupational exposure does occur. So that's something that you have to be aware of as well.
Yes, and I just couldn't fit that in. I was originally going to, my team here said, oh, a lot of those interesting staff exposures that we have where we've had radioactive waste in the wrong area, or we've had staff walking into a CT scanner while it's being calibrated, but they're all very, very, very low dose. So that's why I've not included them in the presentation today and decided to concentrate on the patient exposures.
Yeah, they're the frustrating, interesting, frustrating, can look back and laugh at, but not as complex. So Gary, who's out at Liverpool, Radiation Oncology Physics, he wasn't aware of the PCMX rotational tool. But do you know, obviously the use of cone beam CT is now pretty standard across all of oncology. Is there a better tool that you know of for cone beam?
Look, I haven't done any radiotherapy cone beam estimate. I'm trying to think, maybe for an ethics project, Gary, I probably based it on your estimates somewhere along the line. I'm feeling like I saw a research project that involved you. So look, the rotational module is quite good. I don't use it a lot, but it is probably something to look into. But otherwise, I treat them a bit like a fluoroscopy unit. So it is doing that same type of dosimetry through PCXMC, where you can break it into a number of projections, or you know, subdivide it into different angles so that you're getting.
We do that, and the calculation takes about an hour or two.
Yeah,
so
no, you should look at the rotational.
Painful.
Well, you probably got the rotational module.
I don't. I wasn't aware of it. So
okay,
I've already sent off an email to ask.
Oh, there you go. There you go. So that might have solved. I actually think I ended up using it when verifying. I don't know if it was you, Gary, but I did verify a dose estimate, which I think I then used the rotational module very, very easily. It was good to use because you can do a bit of a batch run of the angles. So you decide how much you want to split the 360 degrees into.
Yep, sounds good. Thanks.
Oh, wow. Okay. Yeah, no, that definitely, I haven't even seen that component of it, so that's great to know. Just a couple of comments more than anything. So just a reiteration, I think, based on what you've already told us, is to make sure that what you're being provided with for your incident report actually is the right parameters coming out. I've asked for someone to give me the parameters, and they give it to me, and I said, well, what with the units? And they say, oh, yeah, decigrade per centimetre squared, but then you look it up and it's not. So you've just got to make sure you've got those right units.
And I think that's where having a template to collect the information helps prompt you ask the right questions. If I've done a dose estimate, you know, we have a lot of dose estimates on file now, so I know what I'm expecting to find out. So even if I've got the column where I'm collecting all those parameters, I might have another column written off to the side with what my expectation is, so that if I get a number that is way off, I clarify and confirm it at that point in time, because often it is due to the dose units. And often you'll find if a clinical staff member is really rushed, they'll say, yeah, that's what it is. But it may not be. So there's always value. You cannot always do this, but there is always value in actually going to the workstation of the X-ray unit, or, you know, having a look at what was actually done, speaking to them while it's still fresh in their mind. And then, of course, the DICOM header has a lot of information which you can rely on.
Yeah, and I think this might be Thomas Cron had just pointed out, from a therapeutic skin dose with their stereotactic, up to 20 gray may be acceptable. So it's interesting, but we're obviously looking at the different area of skin and what they're doing. So
yeah, no, that is already.
Have you got the chat up now? I couldn't remember if you've got the.
Yeah, I can see it a bit to the side, not all of it. So no, it's helpful. And Thomas and I sit on the Victorian Radiation Advisory Council committee, and I very much wanted to discuss the issue of nuclear medicine extravasations and whether we report those or not. It has been, you know, flagged for a while that we want to have a bit of a discussion around that. But certainly with skin doses, we can learn a lot from our oncology colleagues, and I certainly do go to them whenever we have these sorts of high dose ranges and we're wanting to talk about these skin effects.
So I'll just finish with one question, because we're running out of time. How do you actually get the incident reports and information provided to you? Obviously, I think you are an RSO. Your facility does.
I walk out into the corridor and I get told of incidents. So I've been here for a long time, so I'm well known, and I'll often just be phoned or emailed directly. And part of what I've done in establishing the reputation of the physics team here at the Alfred is to ensure that happens. So we're very visible within our department, and would hope that we're pretty much told of things as they occur. But we then rely on our formal reporting system, which is Riskman here at the Alfred. So any incident or near miss will be logged in that, and anything at all to do with radiation or that occurs in radiology or the cath labs, all of them come to me. So I, you know, even an N95 mask has, you know, caused my nose to bleed today. Like that, I will get everything that occurs in those departments. So I'll get, I don't know, 8 or 10 a day, and there will be maybe 5 or 6 a week that I follow up that are radiation related, and maybe 1 every couple of weeks is reportable.
Yeah, I think that the biggest one is is starting that, getting that culture of reporting, that it's not a bad thing to report. It's a learning mechanism more than anything. And it's best practice for our patients. So it is hard when things are not regulated, but just to get things, we use IMS Plus here at New South Wales Health, so lots of that goes through there, but it's getting people to that stage. And I think it's just getting, as you said, getting your face out there and talking to the right people to make sure that it's filtered down. But I think we better wrap up. We've run a bit over time, but I think that was an excellent presentation, Zoe. Thank you so much.
Thank you for inviting me, Nicole. Really enjoyed presenting it.